our third episode, and we are going to present the case number 5 and case number 6 today. We are fortunate enough to have as examiners Dr. Sriram Chandramurthy, Associate Professor of Ophthalmology from Gayatri Institute of Healthcare and Medical Sciences, Medical Technology of Visakhapatnam. He has a very bad sore throat and is being suffering from fever for the past 4 days. Still, he's so enthusiastic enough, and he said, "Yes, I will come and participate in the program." Thank you very much, sir. I really appreciate that. And we have our dynamic Dr. Krishnamurthy Garu. He's a professor of ophthalmology, Sri Balaji Medical College, Hospital and Research Institute, Tirupati. Welcome, both the examiners. And today's moderator is none other than our very dynamic secretary, Dr. C.V. Gopal Raj Garu. Welcome, Dr. Gopal Raj Garu.
Sir, good evening, sir. Good evening, sir. Raj Garu.
Good evening, sir.
Good evening, sir.
So today's cases are going to be presented by Dr. Srujana Thota, from a third-year postgraduate from GMC Srikakulam.
Good evening, Rajgar.
Good evening, sir. Good evening.
Sir, good evening, sir.
Good evening.
Good evening.
The second case will be by Dr. Raghav Gupta. He is a first-year postgraduate from AMC Government Regional Eye Hospital, Visakhapatnam. So we have mentors, Dr. K. Padmavati, Professor and In-charge HOD of GNC Srikakulam, and also Dr. V. Meenakshi, Professor and HOD AMC Government Regional Eye Hospital, Visakhapatnam.
Good evening, sir. Good evening, everyone.
I welcome all of you, and I hand over the proceedings to Dr. Gopal Raj Garu to moderate this session and have a very good session, useful for the postgraduates. Over to Dr. Gopal Raj Garu.
One word, Rajesh.
Yes, sir.
My appreciation to you, because this is the first time we are starting this sort of business, It's a very nice initiative, and this is going to be very useful for the PGs. Not only it increases the skill, the presentational skills, but also the fear complex will be out of this thing, In the examination, apprehension, fear, everything will be relieved.
That's exactly our idea, sir.
Very good.
Thank you very much for your kind words, sir. Over to Dr. Gopal Raju Garu. Dr. Gopal Raju. Dr. Gopal Raju. Dr. Gopal Raju. Okay. The first case will be by Dr. Srujana Thota. Dr. Srujana, can you please share your screen?
Yes, sir.
She is going to present to us lens-induced glaucoma. Yes, you can start your case.
Is it visible? Yes.
It's visible,
Yeah.
very
Visible.
I request all of you to mute your mics, except for the examiners and the mentors. Go ahead, Dr. Srujana. Please start.
Good evening, everyone present here. I'm Dr. Srujana Thota, pursuing final year post-graduation Department of Ophthalmology from Government Medical College, Srikakulam. I'm going to be presenting a case under the guidance of mentor Dr. K. Padmavati Madam. I'm going to start the case presentation. A 77-year-old female patient, P. Santama, who is a housewife, came from Srikakulam with chief complaints of defective vision in the right eye since 1 year, pain in the right eye since 1 month, and redness in right eye since 1 month. Coming to the history of chief complaint, patient was apparently normal 1 year back when she complained of defective vision in the right eye, which is gradual in onset and progressive in nature. She had a sudden onset of dull pain and redness in the right eye 1 month back and is progressing, which is associated with headache and watering. There is no history of any ocular trauma, no history of vomiting, discharge, double vision, floaters, or colored halos. Coming to the past history, she is a known case of diabetes mellitus and hypertension since 20 years and is on medication. She has no other systemic illnesses, no history of usage of any drugs in the past other than oral hypoglycemic agents and antihypertensives. She underwent cataract surgery in the other eye, which is left eye, 5 years back, which was uneventful. There was no history of any past ocular surgeries in the right eye. No history of usage of spectacles. She has normal sleep and appetite and regular bowel and bladder habits. Patient consumes mixed diet. Coming to the family history, no similar complaints in the family members were seen. In general examination, patient was moderately built and
Okay,
nourished.
only positive. Tell me the positive point.
Yes, only short case, short case. You
Fine.
need not
Yes.
tell all.
Yes. On cardiovascular examination, respiratory system examination, it was normal. Respiratory rate was normal, 16 breaths per minute. Pulse rate was normal. Blood pressure was 140 by 90 mmHg, and she was afebrile. Coming to local examination, the head posture was normal, normal facial symmetry, and normal forehead. Coming to the ocular examination at the time of presentation of the patient, the best corrected visual acuity in the right eye was perception of light with projection of rays in all four quadrants. Near vision was not able to be elicited. At an X-ray, there was lid edema present. Upon lacrimal syringing, it was patent.
PL and
There was
PR indicates what internally, Sujana?
that retina is normal, sir. So the patient
Both PL and PR indicates retina.
What exactly the PL indicates? PL present means?
that the macula is intact, sir.
It's a
PR
macula.
is
Whereas PR?
PR is the peripheral retina, so all the whole quadrants indicates that the peripheral retina is normal, sir.
Okay.
Proceed.
Yes.
The patient had conjunctival congestion and circumcorneal congestion. The sclera was normal. Cornea was 11 mm horizontal into 10 mm vertical size. There was diffuse epithelial and stromal cordial edema present. The endothelium is studded with white matter, which suggesting of lens particles. Coming to the anterior chamber, von Herrich's grade 3 was the depth. There was milky appearance suggesting of cortical matter in the anterior chamber, which is obstructing the visualization of further ocular structures. There was 2+ flare present in the anterior chamber. The right eye iris was hazily seen due to the corneal edema. Pupil was 5 mm in size, white, round, and fixed. The lens was found to be hypermature cataract. The intraocular pressure with Goldman applanation tonometry performed at 11 o'clock a.m. was 48 millimeters of mercury. Coming to the fundus examination was done undilated. There was no red glow. The media was hazy and other details could not be seen. Coming to the left eye, the best corrected visual acuity was 6/12 unaided. Near vision was plus 2.5 sphere coming to N6. And next were within normal limits. Upon lacrimal syringing, it was patent. Coming to conjunctiva, it was quiet in the left eye. Sclera was normal. Cornea was 11 mm horizontal into 10 mm vertical and clear cornea. Coming to the anterior chamber, left eye, von Herrich's grade 4, which was deep and quiet. The iris had normal color and pattern. The pupil was 3 mm, round and reacting to light.
What are the, Surya, one question. What are the other methods to assess the anterior chamber depth?
Torchlight test.
And? What are other investigative procedures where you can assess the anterior chamber depth?
Clinically, only one method. Any other method is there? You said Van Herrich's
yes.
torchlight test. Any investigations?
Is the OCT useful?
Anterior segment OCTs.
UBM?
UBM.
Ultrasound.
Okay, carry on.
The lens was pseudophakic. Intraocular pressure with Goldman applanation tonometry performed at 11 o'clock a.m. was 20 millimeters of mercury. Fundus examination was done using indirect ophthalmoscopy after dilatation. Red glow was present. Media was clear. Optic disc normal size, shape, color, margins were well defined.
So, one question.
Yes.
What is the basic principle of indirect ophthalmoscope?
To visualize the fundus, sir, which is going to be inverted.
What is the basic principle, underlying principle in indirect ophthalmoscopy?
Indirect ophthalmoscopy, direct ophthalmoscopy.
Direct ophthalmoscope.
Because this is mainly for, this is only meant for basics, no?
Yes.
Okay.
Direct ophthalmoscopy will be seeing an erect image, sir. Indirect ophthalmoscopy is going to be an inverted image, sir.
Okay, you are making the eye hypermetropic by placing convex, strong convex lens. Okay, Carry on.
Cup disc ratio of left eye was 0.3:1. Arteries to venous ratio is 2:3. The periphery was within normal limits. Foveal reflux was present. Coming to gonioscopy at the time of presentation, structures were not visible in the right eye due to corneal edema. In the left eye, the superior quadrant, you could see anterior trabecular meshwork. The other three quadrants, posterior trabecular meshwork, was visualized.
What is the underlying principle of gonioscopy?
Total internal reflection.
What is the total internal reflection? What is it? How gonioscopy is helping?
If the ray of incidence is more than the critical angle, sir, there will be total internal reflection.
What is that critical angle? How much? Cornea and eye. Okay, it is 46 degrees. It is eliminating the corneal surface, no? Okay.
Yes, sir.
So can you see, can you do gonioscopy in the presence of corneal edema? Is it possible?
No, sir.
Then how to examine the angle by gonioscopy?
In gonioscopy, you won't be able to see when there is corneal edema, sir. So we can go for ASOCT.
Suppose there is an epithelial edema, can you remove it and see?
We can administer hypersol, sir.
Yes.
Topical hypersol.
Reduce the corneal edema by putting hypersol, and then you can try still.
Yes.
Okay, right. Go ahead.
B-scan of the right eye was done, showing ultrasonography of the right eye shows moderate to high reflective echoes noted along posterior lens surface and in the vitreous, suggesting of vitritis. Retinal choroid scleral complex was intact. Coming to the summary of the case, a 77-year-old female housewife from Srikakulam presented with complaints of gradual progressive diminution of vision in the right eye since 1 year, followed by sudden onset dull pain and redness in the same eye for 1 month, associated with headache and watering. She is a known case of diabetes and hypertension since 20 years and is on medication. She underwent cataract surgery with PCIOL implantation in the left eye 5 years ago for defective vision. On ocular examination, it revealed best corrected visual acuity in the right eye was perception of light and projection of rays, and left eye was 6/12. Right eye, there was lid edema, conjunctival congestion with circumcorneal congestion, diffuse corneal edema, and cortical matter and turbid aqueous in anterior chamber with hypermature cataract. Left eye was pseudophakic. Intraocular pressure in right eye was 48 millimeters of mercury, and left eye was 20 millimeters of mercury. Gonioscopy findings were documented suggesting open angles in the left eye and unvisualization of angles in the right eye. B-scan of the right eye had moderate to high reflective echoes noted along the posterior lens surface and in the vitreous, suggesting of vitritis. Provisional diagnosis is a case. This is a case of right eye phacolytic glaucoma with hypermature cataract and left eye pseudophakic. The investigations done were B-scan.
Wait.
Yes.
I have phacolytic glaucoma and the hypermature cataract in the right eye.
Yes.
How will you account for vitritis?
So the lens proteins, they seep through the micropores from the anterior lens capsule as well as the posterior lens capsule, sir. If they seep into the vitreous through the posterior lens capsule,
then it is called as vitreous. Then it is called as vitritis.
There is inflammation of the vitreous as well.
When there is an inflammation in the vitreous, why not in the anterior chamber?
Same
proteins are releasing into the anterior chamber also, no?
Yes, so there is flare and milky white substances, pseudohypopyon in the anterior chamber.
There is no KPs. KPs are not there to say uveitis. How will you get the flare in uveitis?
It is due to
why not the lens proteins that eye echo particles can be lens proteins in the vitreous?
Yes, sir.
And then how can you tell that it is vitritis?
What are the different mechanisms by which you can get cataract glaucoma in this different how exactly the glaucoma happens?
Sir, in this case, which is phacolytic glaucoma, there is release of lens proteins from the intact anterior lens capsule or posterior lens capsules, sir, into the anterior chamber, and there is reaction with macrophages engulfing the lens proteins and directly blocking the trabecular meshwork, sir, hence increasing the intraocular pressure, sir.
Any other? Only one.
if it was a phacomorphic glaucoma, sir, there will be increased AP diameter.
Phacolytic, your case.
Yes, sir.
Your case is
Phacolytic glaucoma, sir.
okay, macrophages.
Macrophage theory, or there is direct high molecular weight proteins leaking, which directly block the trabecular meshwork.
Blockage.
Macrophage theory is when macrophages engulfing the lens proteins.
Inflammation will be there, because these lens particles, they also elicit certain.
Trabeculitis will occur.
So trabeculitis will be there, trabecular meshwork blockage will be there.
Blockage will be there.
Lens matter as well as these macrophages. So these are three mechanisms, and certain amount of inflammation also, iritis also, because of lens protein.
Leak lens proteins.
That these are all the different mechanisms by which you can get glaucoma in.
Phacolitis.
Okay. Yes, come on.
Srijana, one more question.
Yes, sir.
Patient underwent cataract surgery for the other eye, left eye.
Yes, sir.
So this case may be this eye, the right eye may be this one phacoanaphylactic reaction. I will exclude that one.
Sir, the left eye surgery was done 5 years ago, which was uneventful, sir.
Okay, no problem. Because lens matter is exposed, no?
Yes, sir.
How can you exclude? How can you identify that this is not phacoanaphylactic glaucoma?
So there's usually history of trauma in the same eye or surgery, sir.
It may be surgery or trauma, anything that exposure to the lens proteins to the immune system of the body.
Yes,
and
sir.
same thing happens in the future also.
Phacoanaphylactic usually we see within 2 weeks of trauma or surgery, sir.
Only main excluding point is the absence of KPs.
Granulomatous. Granulomatous KPs.
No KPs. Yes.
Okay.
That is the characteristic sign.
Okay, carry on.
Yes.
Coming to the investigations done were B scan, random blood glucose levels, which was normal 108 mg per dl.
Okay, leave it that investigate. Okay, leaving that. Any other cause that lens can cause glaucoma apart from this?
Phacomorphic, phacolytic lens particles or ectopic lentis.
Ectopic?
Ectopia lentis.
Ectopia lentis
types
also
of,
cause.
Types of lens induced.
Phacotopic glaucoma.
Phacotopic is when the lens particles released after trauma, sir.
No. It is the lens which is placed in a different position, which can cause a blockage, pupillary block. That is the reason. So it is otherwise ectopia lentis. Otherwise ectopia lentis. Okay.
What is the cause for ectopia lentis?
Subluxation of the lens of microspirophakia, dislocation of the lens.
Or other causes?
Syndromic causes are axial field rigor, Marfan syndrome, homocystinuria, or any trauma. Sir,
what are the ocular causes?
They can. In hypermature cataracts, when there is weakening of the zonules, so there can be subluxation of the lens, sir.
What is inverse glaucoma?
Sir?
Inverse glaucoma.
Lens related. That is also lens related.
Normally, for glaucoma, for primary open angle glaucoma, what is the drug you use? Time-tested, old traditional drug.
Prostaglandin.
Pilocarp.
Older. Nowadays, nobody uses it.
There's a pilocarp.
Parasympathomimetic. Yes, pilocarpine. It constricts the pupil, myotic. Induces myosis.
Yes.
Here, normally in glaucoma, that is the treatment. But here, if you put a pilocarpine, because of pupillar block in the presence of microspirophakia, you get a inverse glaucoma. That's why in microspirophakia,
never give
myotic drops like pilocarp. That is the definition of inverse glaucoma. Yes. How do you management?
In this case, we had given injection mannitol 20%, sir, to reduce the IOP, along with topical timolol 2 times per day.
All works.
Sir, I couldn't hear.
How exactly the mannitol brings down the
Hyperosmotic agent, sir. It draws the fluid from the vitreous, sir. So
yes,
hence decreasing the vitreous volume and
vitreous detergence. That is the word you have to. Yes. Any other modality by which you can bring down the pressure?
but topical anti-glaucoma drugs are like beta blockers, sir.
Okay.
Alpha agonists, sir.
Yes.
And acetazolamide, sir, which is a carbonic anhydrase inhibitor.
Yes.
And
What is the adverse effect of acetazolamide?
numbness and tingling sensation, sir, because of
Apart from that, you give for continuously 1 week or 10 days, whatever.
hyperkalemia,
And that you must take care of that.
Contraindication?
kidney failure, sir, congestive heart disease,
Chronic kidney disease and heart problems.
heart failure.
Yes.
Hmm.
Yes. Tell me what surgery you do. Suppose the pressure is not coming down, then what to do?
If just half an hour before surgery, we will give mannitol, sir.
Yes.
Even still, if the pressure is not decreasing, we can do controlled AC paracentesis, sir, so as to not cause sudden decompression, sir.
What problem will arise? There is a sudden decompression.
Choroidal detachment, sir.
What is that hemorrhage called? Choroidal. Yes, choroidal. What is the hemorrhage? Name of that hemorrhage?
Suprachoroidal hemorrhage.
Yes. Expulsive hemorrhage. Expulsive. Yes, it's nothing but suprachoroidal.
Suprachoroidal hemorrhage.
Sudden release of pressure over choriocapillaries, sudden expansion, dilatation leading to massive hemorrhage. Yes.
Expulsive hemorrhage.
Sujana, why do you think it is phacolytic? How do you differentiate between phacomorphic and phacolytic?
In phacomorphic, ma'am, there'll be bulged lens, ma'am, and anterior lens capsule is intact. There won't be any reaction in the anterior chamber, ma'am. It will be blocking there'll be pupillary block in phacomorphic glaucoma, ma'am.
What is
In
G sign?
What is the mechanism in phacomorphic? Mechanism of raising the what is the cause for raised IOP?
There is pupillary
What's
block
the
because of
mechanism?
the lens vault is pushed forward, ma'am. Because of the bulging of the lens that causing a pupillary block. Hence, there won't be a way for the drainage
There is
of
lens, anterior surface of lens. There is opposite lens
opposed to the
opposition with the iris.
posterior surface of the iris. So pupillary
So
block.
next sequence of events.
You told
Next
that
what happened?
you told that some vault.
Iris.
What is that lens vault?
It's the imaginary line drawn from scleral spur, sir. If it is anterior to its anterior placed vault, sir, to that line. If the lens is placed anterior to that line, sir, it's anteriorly placed lens vault. That causes more transfer apposition of the iris.
That is both scleral spurs and from the anterior surface of the lens to this horizontal line.
Yes.
Well, that is the lens vault normally will take into that. That is more important in this one, angle closure glaucoma. But here is because what are the stages of cataract formation, anal cataract formation?
In phacomorphic, there is bulging of the lens.
So, what are the stages of
increase
anal
AP.
cataract formation? What are the stages of anal cataract formation?
He's asking for the stages of senile cataract formation.
Stages of cataract formation.
How does a cortical cataract, what are all the stages? Stages of hydration, lamellar separation, all these things will be there, no?
Because in immature cataract, because continuous accumulation of fluid, the anterior posterior diameter of the lens is increases and push the iris forward and blocks the trabecular meshwork and develops. Okay. And you told that hypermature cataract. What is these are all undergraduate questions. What is the important sign to say the cataract is hypermature?
Morgagnian.
No. What are the important sign to say that cataract is hypermature? Mature
There
and
is
hypermature both are same appearance, no?
Yes, sir.
But the only thing is, in hypermature cataract, you must see the calcified spots on the anterior lens surface. Then only it called as a hypermature cataract. Okay. Now you are going for surgery. What are the important precautions you have to take in the surgery during this procedure?
We have to make sure that there is no sudden release of pressure, sir. So controlled AC paracentesis can be done, sir.
Okay.
And after during capsulotomy, sir, we have to make sure there is no extension of the flaps, agitated flag sign, sir. So we can give a puncture in the center, sir, so as to release the lens material, sir.
You must also very careful because jonules are also weak in this case.
Yes, sir.
So must always take care of that one.
Yes, sir.
Can you go for IOL?
Then for capsulotomy, we can go for orange peel technique, sir, where controlled rexis can be done, sir. After we're not supposed to do hydrodissection, sir. There are chances of posterior capsule rupture.
In which cataract PC rupture is more? Hydrodelineation done. Which type of cataract you do only hydrodelineation?
In posterior polar cataract.
Yes, posterior polar cataract. That is the only condition where you do only
hydrodelineation.
Because of fear of PC?
PC rent, sir.
How to detect PC rent preoperatively? How can you detect preoperatively? There is a dehiscence of posterior capsule.
Usually posterior capsule is taut, sir. If there is fluttering of the posterior capsule or the alteration in the red glow, sir.
Any investigation by which you can identify these dehiscence? Latest.
Pistile sign.
Anterior segment OCT.
Pistile sign?
OCT, optical coherence tomography. By that you can identify dehiscence.
Posterior capsule.
Yes.
And during capsulotomy also, you can the capsule is very flappy. It will not go forward.
Wrinkles will.
Yeah, wrinkles will form an anterior capsule. And jonules, even jonules are weak also. It gets that. And while prolapsing the nucleus will not come easily when there is a rupture is there.
Yes, sir. There will be sudden deepening of the AC, sir, and the pupil will get constricted.
Okay.
It's difficult to remove the nucleus.
How do you manage phakomorphic glaucoma? Phakomorphic.
Sir?
Phakomorphic glaucoma.
Phakomorphic glaucoma, there will be a pupillary block, sir. Because of that, there is rise in IOP, sir, causing iris Bombay.
Yes. What is the treatment for iris Bombay?
Laser peripheral iridotomy.
Iridotomy, laser iridotomy sometimes reduces pressure.
Yes.
Then you can proceed the other treatment, other line of management of glaucoma, and then finally surgical.
Yes.
How to know that there is an anterior peripheral anterosynechia? What is dynamic gonioscopy? What is indentation gonioscopy?
Or if there are peripheral anterior synechia, sir, or indentation gonioscopy, there won't be any release of there won't be visualization of the angle, sir. But usually confused with iris processes on indentation, we can see the angle structure, sir.
What is dynamic gonioscopy?
On indentation,
eyes. Patient moves his eyeball during gonioscopy and you can visualize the angle. Yes, you have to you can exclude positional angle closure or peripheral anterosynechia. If there are peripheral anterosynechia, what is your line of management?
Peripheral anterior synechia, if it is present, sir, we can go for trabeculectomy, sir, along with cataract extraction.
Not coming down even after extraction.
Even after medication.
Extraction of the lens. Till then, you can plan for
trabeculectomy.
Filtration surgery. Okay?
Yes, sir.
Doctor, any other questions?
Okay, sir. You did
one
well.
more case there, we can
yes, sir. One more.
go to that.
Okay.
Okay.
Isn't good? Well done.
Yes. Sir Ramachandra Murthy, if he wants to put some questions, let him.
Murthy garu, Murthy garu.
Dr. Sridhar, stop sharing.
Yes, sir.
Continue, sir. Thank you.
మూర్తి
Okay.
గారు ఏం మాట్లాడలేకపోతున్నారు, అది
Okay, no problem.
షాడో ఈజ్ టాకింగ్.
Let us go to the next.
అది షాడో ఈజ్ టాకింగ్, సార్.
Excellent presentation, Dr. Srujana.
Thank you, sir.
Dr. Gopal Raju, are you there?
But why there's a final year postgraduate is given a simple case and first year postgraduate the CRV.
You asked a lot of questions, sir. That is, you extensively covered her with whatever possible questions are there.
Okay, right.
Yeah, over to Dr. Gopal Raju for the next case.
Okay, sir. Can start?
Yes, sir.
Good evening, sirs and ma'ams.
Screen
Dr.
is not
Raju,
available.
share your screen first.
Good evening, professors. Today I'll be presenting a case under the guidance of Dr. V. Meenakshi ma'am and Dr. G. Premlata ma'am. I'm going to be presenting a case of P. Kanakaraju, who's a 53-year-old male, an auto driver by profession, and hails from Jagdamba Junction from Visakhapatnam. He presented to GRH with the chief complaint of sudden painless diminution of vision in right eye 2 months back. Moving on to the history of present illness. The patient presented to GRH 3 weeks ago, complaining of sudden diminution of vision in right eye 2 months back, which was sudden in onset, non-progressive, persistent, and painless. There was no history of redness and eye pain. There's no history of colored halos, no history of trauma, no history of jaw claudication. There's no history of transient loss of vision, no history of flashes and floaters, no history of frequent changes of reading.
Raga, one question. You told that colored halos. Where you see the colored halos normally?
So the
What condition?
colored halos can be seen in glaucoma as well as cataract, sir.
What is the mechanism of cataract?
In cataracts, so there will be alternating fibers which would be opacified and cleared as well, sir, which would lead somewhat to a prismatic effect and cause the dispersion of light, which would lead to the halos. And in glaucoma, it would be due to the increased.
Any other condition apart from this? Any other condition?
Glaucoma as well, sir, due to.
Okay. Glaucoma and cataract. About what the third one?
Third one.
Corneal edema.
No.
Which will be completely abolished. It's a transient phenomenon.
Just wipe
and
out.
There is some mucopurulent.
You can discharge and it disappears.
That mucopurulent conjunctivitis. That mucopurulent discharge stays on the cornea, acts as a prism. Okay, carry on.
What is the test which differentiates glaucomatous halo and lenticular halo?
So we can differentiate the two halos by a test known as the Finchem's test, in which we pass the light through a stenopic slits.
That's enough. If you say that, that means you know.
Okay, carry on.
So there's no history of frequent change of reading glasses. There's no history of ocular surgery. There's no history of any drug usage or no history of any headache as well. Moving on to the past history, there's no history of similar complaints in the past. The patient is a known case of hypertension and diabetes mellitus since 2 years. There's no history of cerebrovascular accident, coronary artery disease, tuberculosis, or asthma. Coming to the personal history, the patient takes mixed diet, has regular bowel and bladder habits. There's no history of smoking or alcohol consumption.
What for you are asked asthma in this history?
Sorry, sir?
What for you have asked asthma?
Bronchial asthma.
Routinely you asked or anything else related to the eye or eye?
So we ask routinely as well, and
no, there is some relation with the eye.
Sir, for beta blockers, if we are prescribing beta blockers, eye drops as well, sir.
For asthma?
Not for asthma, sir. For glaucoma, often we prescribe beta blocker.
I am asking about asthma. What is the treatment for asthma?
Steroids, sir. Steroids, yes, sir. So the patient is using steroids, it can lead to cataract formation or glaucoma formation as well.
Okay, carry.
Beta blockers are contraindicated in bronchial
Yes, sir.
What beta blockers? Selective?
Non-selective, sir. Non-selective. Because they lead to bronchoconstriction as well, sir.
Okay, right.
Which can exacerbate an attack of asthma, sir.
Yes.
Okay, carry on.
Coming on to the treatment history, the patient is currently on tablet amlodipine 5 mg OD, tablet telmisartan 40 mg OD, tablet atorvastatin 20 mg Horasomi, tablet metformin 500 mg BD, and tablet glimepiride 1 mg OD. Moving on to the family history, there's no history of similar complaints in the family. On general examination of the patient is conscious, coherent, and well cooperative. The patient is well built and well nourished. There is no pallor, icterus, cyanosis, clubbing, pedal edema, or lymphadenopathy present. The vitals of the patient is afebrile. The pulse rate is 80 per minute. The respiratory rate is 17 per minute, and the blood pressure is 180 by 100 mm of Hg. Moving on to the systemic examination. CVS, respiratory system, per abdomen, and the CNS examination are all well within normal limits. Moving on to the local examination, the head posture is normal. The facial symmetry is bilaterally symmetrical, and the extraocular movements are full and free in all the cardinal directions.
What are the extraocular movements?
Extraocular movements, we have primary gazes, sir.
Okay. What are they?
8 primary gazes, sir.
What are they?
Superior, inferior.
What are the ductional movements? What are the version movements?
The movements are elevation, depression.
What are the ductional movements? When do you call a ductional movement?
Tell
When
you
do you call?
what are the duction movements? What are version movements? What is the definition for duction movement? When do you call duction movements?
Adduction and abduction.
You want to see with binocularly or unicularly or both?
Both we see, ma'am. We often compare as well from one.
Sir, my charge is over. My laptop charge. Called ductional movements. When both are simultaneously, they are called version movements. Okay.
Yes, sir.
What is the importance of version movements?
So to measure the secondary and the primary deviation and compare between the, if any strabismus present because of paralytic or non-paralytic squint, sir.
Most important is some of the muscles overaction or underaction only assessed by the version movements.
Yes.
Okay, carry on.
Coming on to the anterior segment examination, right eye, the uncorrected visual acuity is counting fingers at 2 meters, which improved to 624 partial with plus 1.75 diopters spherical lens in combination with plus 1 diopters cylindrical lens at 20-degree axis. The eyelids are normal, conjunctiva is quiet, cornea is clear, anterior chamber depth is VH3, and the contents are normal. Iris color and pattern are normal. The pupil is normal in size and reacting to light, and the lens status is early lenticular sclerosis. This is the anterior segment photos of the right eye. Coming on to the anterior segment examination of the left eye, the uncorrected visual acuity is 6/9, which improves to 6/6 partial with usage of -1 diopter cylindrical at an axis of 90 degrees. The eyelids are normal, conjunctiva is quiet, cornea is clear, the anterior chamber depth is VH3 graded, and the contents are normal. Iris is normal in color and pattern. The pupil is normal in size and reacting to light. The lens status is early lenticular sclerosis. These are the diffuse and slit photos of the anterior segment of both right and left eyes. On intraocular pressure examination by Goldman's supplination tonometry, it was found out to be 26 mm of Hg in the right eye and 22 mm of Hg in the left eye at 11:45 a.m. The central corneal thickness in right eye is 522 micrometers and in the left eye 534 micrometers. On gonioscopic evaluation of the patient in the right eye, scleral spur could be seen in all the 4 quadrants. In the left eye also, scleral spur can be seen in all the 4 quadrants with dense pigment deposition in the inferior quadrant, which could be graded as 2 as per Shee's classification in both the eyes.
What is the importance of this CCT?
So CCT in cases of glaucoma, sir, there be increased in corneal central thickness, sir, which could lead to false interpretation of the intraocular pressure, sir, by the applanation tonometry. Thicker corneas would lead to false lower IOPs, and thinner corneas would lead to an overestimation of the IOPs, sir.
Yes, okay. There is a correction factor, you have to correct it, and then
Yes.
that is corrected.
Various
Okay,
formulas are present, sir, according to which, according to the, depending upon the central corneal thickness, we have to apply those correction factors to estimate an accurate intraocular pressure.
carry on.
Coming on to the fundus examination, so the right eye, the media is clear. In the optic disc, the size, shape, color are normal. There's mild blurring of the inferior disc margin, with the cup disc ratio being 0.7 ratio 1 cup disc ratio. Physiological deep cup is present, and with superior rim thinning it can also be appreciated. Spontaneous venous pulsations were absent, sir, with nasalization of vessels. Laminar dot sign was present, and disc hemorrhages could be appreciated in the inferior NRR region, neuroretinal rim region. Peripapillary edema and hemorrhages were present. The vessels, there was marked arteriolar narrowing along with venous tortuosity and dilation. The arterial venous ratio was found out to be 1:4. On macular examination, foveal reflex was absent due to macular edema. A couple of cottonwool spots could be appreciated on the retina. AV crossing changes were found to be present, more specifically the Salu sign. Multiple superficial retinal hemorrhages could be appreciated throughout the fundus in all the 4 quadrants, sir. This is the right eye fundus picture, sir. The media is clear. Coming onto the disc size, shape, color are normal. There's mild. So I'll see if I can. There's mild inferior disc margin blurring as well as superior NRR thinning, and 0.7 cup 0.7 ratio 1 cup disc ratio, with the nasalization of vessels and laminar dot sign could be appreciated over here, sir. With disc hemorrhages present over the inferior neuroretinal rim area, marked by the green arrow, sir. Coming onto the vessels, there's marked arteriolar narrowing, sir, combined with the venous dilation and tortuosity, which can be appreciated all through the fundus. Coming onto the macula, this is a better picture for the macula. Macular edema, foveal reflex is absent due to presence of macular edema, along with the presence of a cottonwool spot, which is marked by the blue arrow. It can be appreciated here as well as the inferior margin over here, sir. And multiple superficial retinal hemorrhages are present all throughout the fundus. Coming on to the left eye, the media is clear. Optic disc size, shape, color are normal. Margins are well defined. Cup disc ratio is 0.5 ratio 1 cup disc ratio with a physiological deep cup. Neuroretinal rim is healthy. Vessels over the disc are normal. Spontaneous venous pulsations could be appreciated. Peripapillary atrophy was present. On vessels, there was marked arteriolar narrowing along with venous dilation, and the arterious venous ratio was found out to be 1:3. Foveal reflex is normal with AV crossing changes present in the fundus, again, Saru sign. Coming on to the picture of the left eye fundus. So the media is clear. Optic disc size, shape, color are normal. Margins are well defined. Healthy neuroretinal rim with 0.5 ratio 1 cup disc ratio. Venous, coming onto the vessels, there is marked arteriolar narrowing present with venous dilation. Coming onto the macula, the foveal reflex was present, sir. Yes, and marked by the white arrows, we can see the AV crossing changes, which are the Salu signs, sir. So in summary, a 53-year-old male came to our OPD with chief complaint of sudden painless diminution of vision in right eye 2 months back. On examination, the best corrected visual acuity was right eye 624 partial and left eye 66 partial. Fundus examination, right eye, there was 0.7 cupping with the deep cup, mild inferior blurred margins, thinning of superior neuroretinal rim, along with laminar dot sign, nasalization of vessel, disc hemorrhages present along the inferior neuroretinal rim margins. Peripapillary edema with hemorrhages could be appreciated. with marked arteriolar narrowing, venous dilation, macular edema, and cottonwool spots, and multiple retinal hemorrhages throughout the fundus in all the four quadrants, along with AV crossing changes, that is the Selous sign. In the left eye fundus, 0.5 cupping would be seen with peripapillary atrophy and marked arteriolar narrowing, and again AV crossing changes, which is the Selous sign. Moving on to the investigations part, so my provisional diagnosis is right eye non-ischemic central retinal vein occlusion with macular edema with primary open angle glaucoma, and in the left eye, primary open angle glaucoma suspect with grade 2 hypertensive retinopathy. Coming on to the investigations which we ordered for the patient are, so the differential diagnosis for for the condition are ocular ischemic syndrome, diabetic retinopathy, radiation-induced retinopathy, and hyperviscosity syndromes.
Raghav, just wait.
Yes, sir.
Yeah, first of all, congratulations for a very good documentation of the entire case, especially the fundus picture. You have all the montage you have done a very good job.
Thank you, sir.
But only thing, coming back to your provisional diagnosis, why it is non-ischemic?
So there are a variety of factors which led me to think it was non-ischemic. A couple of being that the RAPD was absent in the patient, sir. Pupils was normally reacting to light, sir. There was relatively preserved vision, sir. The best corrected vision was 624 partial, as opposed to in ischemic cases, it would be worse, often less than 660, sir.
Okay.
And we'll have to have at least 10 disc diopters of non-ischemic area to diagnose it as an...
Yeah, that is further investigation.
Yes, sir.
So clinically, so you should first say, instead of directly saying non-ischemic, you should say central retinal vein occlusion with macular edema, probably non-ischemic.
Yes.
So like that, you have to write the diagnosis. Okay.
Yes.
So your actually this first diagnosis should be primary open angle glaucoma.
Yes, primary, that is the first diagnosis. Yes.
Because that is, so you see, overall, when you finally you want to conclude what is the reason for this CRVO, so
Yes,
you have to support like that. This is a bilateral disease, so first you have to tell that, then you have to tell the ocular, the retinal diagnosis. Okay.
Yes, sure.
How exactly the primary open angle glaucoma produces CRV occlusion?
So basically, what
mechanism?
So the mechanism in this case is when the in primary open angle glaucoma, when the IOP raises, it increases the basic pressure in overall the eye, and which pushes against the lamina cribrosa, sir, which through which the vessels enter, sir. The retinal artery and the retinal vein both enter via that lamina cribrosa. Increased intraocular pressure leads to compression over that, which leads to further compression over there, which leads to venous hypostasis or hyperperfusion, leading to central retinal vein.
Virchow striate.
Virchow striate is, sir, yes, sir. Basically, what happens in that is due to turbulent flow or endothelial damage. There's a thrombus.
Three things, one is endothelial damage, second is stasis, third is hypercoagulation.
Third is hypercoagulability.
Okay, carry on.
Moving on to the investigations we ordered for the patient eye. This is the OCT of right eye, which shows a normal vitreomacular interface with the loss of foveal contour. With loss of foveal contour due to cystoid macular edema, cystoid macular edema with submacular detachment, and with a central macular thickness of 1172 micrometers, sir. The video for the OCT of the right eye, sir.
How will you confirm that it is a non-ischemic?
So we can confirm that on a fluorescein angiography, sir. Non-ischemic areas of non-perfusion could be appreciated of size more than 10 disc diameter, sir.
Any other better one?
Non-ischemic less than 10. More than 10 disc areas means it is ischemic.
Yes, sir. The another method by which we can check that is a more accurate one is electroretinogram, sir, in
Yes.
which there would be decreased B by A amplitude. Normally, B by A amplitude is greater than 1.3. In non-ischemic, it may vary between 1 and 1.3. In ischemic cases, it will be less than 1. ERG and RAPD, if combined together, provides about 97% accuracy.
That is important.
That is-
Okay. And what is the role of FFA in CRVO?
Sir, by FFA, we can diagnose, basically, we can check the non-perfused areas in the retina. And if it's involving the fovea or the macula, the patient is definitely going to have a poor vision, sir, and a poorer prognosis as compared to non-ischemic, sir.
What is the role of fundus autofluorescence?
Sir, fundus autofluorescence in these cases, sir, the intraretinal hemorrhages lead to a blocked or masked autofluorescence. Patchy autofluorescence.
Autofluorescence more specific around the perivenular.
Yes, a fern-like pattern could be seen.
The perivenular, the decrease in hypo autofluorescence.
Yes. Sirs and ma'ams, moving on to the OCT macula of the left eye. The normal vitreoretinal and vitreomacular interface could be appreciated with normal foveal contour.
What is the importance of OCT in CRVO?
Sir, in
Is it useful for diagnosis of CRVO?
So macular edema is one of the causes causing the decrease in visual acuity, sir, which can be appreciated well over in OCT.
Macular edema, okay, mainly.
Yes, sir.
What is OCT angio?
OCT angiography is a very good investigation, a non-invasive, non-drug using method by which we can appreciate the vasculature of the retina, sir, as opposed to fluorescein angiography in which we have to inject a dye. The patient is also uncomfortable. Patient gets nauseated. There might be an hyperreactivity reaction. The patient may be allergic to the dye as well. So it's a non-invasive, non-medical investigative procedure, sir.
But then what is the management?
For sir?
This one.
For this one, sir, we actually, since the patient is having significant macular edema, we planned the patient for a intravitreal anti-VEGF injection. Anyone could be preferred, sir. Ranibizumab,
So
bevacizumab.
management means you must tell what are all the further investigations, and then how do you manage? There are 2 or 3 components here. Glaucoma is there, CRVO is there. So first you must evaluate the patient further. So for that you must tell all the management means investigations and treatment.
Yes, ma'am.
So first you discuss about all the investigations.
Yes, ma'am. Since he's having primary open glaucoma in the right eye, we're bound to have we had the patient undergo visual fields as well, sir. On perimetry, sir, this is a CETA standard 24-2 central Humphreys visual field test, sir, with fixation losses mounting to 5/18, sir, probably due to macular edema, making it an unreliable test, with false positive errors of 13% and false negative errors of 15%, sir. Uh, uh, Moving on to the fields of left eye, it is again a CETA standard 24-2 Humphreys visual field of left eye with 0 fixation losses and false positive errors amounting to 6% and false negative errors amounting to 15%.
In right eye?
Sorry, sir?
Field effect in right eye? In the presenting eye?
Yes, so the field effects are present, but it cannot be, the test cannot be reliable. So there's low test reliability due to the presence of fixation
The
losses.
field effect you get in CRVO?
Sir, central scotoma initially, if the macula is involved, peripheral might be involved.
Large CNP is there, capillary non-perfusion area involving macula. You get a
central scotoma with the on the left eye perimetry, sir. The test is reliable with few paracentral scotomas that can be identified, sir. So we made the patient go through the OCT GCL and RNFL also in the left eye. The OCT GCL infero nasal thinning could be appreciated, sir. And on OCT RNFL, the test was fairly within normal limits. So,
Okay, treatment.
Any other investigations you have added?
Yes, ma'am.
Occlusion.
Since there is CRVO, what are other investigations?
Since the etiopathogenesis of CRV includes a lot of systemic causes, ma'am, we've made the patient go under lipid profile testing as well, in which the lipid profiles was within normal limits. Serum urea, creatinine was within normal limits. Serum homocysteine levels were also within normal limits, but on the higher end of the normal limits, which is another risk factor for CRVO as it leads to hyperviscosity. The glycated hemoglobin was 8.4%, and general random blood sugar was found to be 290 milligram per deciliters. Again, the patient is having uncontrolled sugar and BP levels despite being on treatment. So, which is an independent risk factor again for the central retinal vein occlusion.
Hypertension or diabetes, independent risk factor for CRVO?
Both of them are, sir, risk factors.
Hypertension.
Hypertension is more.
Hypertension is more, yes, sir.
Not diabetes.
Not diabetes.
Yes, sir. Yes, sir.
Why
You
hypertension?
said 180 by 100. Is it with treatment or before treatment? Even with treatment also it is not controlled?
Yes, ma'am. The patient is on tablet amlodipine 5 mg OD and tablet telmisartan 40 mg OD. Despite this treatment, the patient is having high BP. So we've sent a referral. We added some cardiac investigations as well, and the patient was sent to general physician referral and as well as a cardiothoracic vascular surgeon referral due to some cardiac evaluations which we did, which I'll display now. On the ECG, there was P-wave inversion with prolonged QT interval. On a carotid Doppler, atherosclerotic plaque was noted in the right common carotid artery, which could be noticed extending into the right internal carotid artery, causing 55 to 70% of the lumen narrowing of right ICA, internal carotid artery. And on 2D echo, was well within normal limits. So the patient was given a CTVS referral.
Okay, you are giving a anti-VEGF. No.
Sorry, sir.
You started anti-VEGF.
Yes, sir.
How do you follow further?
Basically, and we have to keep the patient on monthly visits for anti-VEGFs, and even after completion of treatment, we have to keep on monthly visits, follow-ups with the patient for at least 6 months, sir.
Okay. Suppose not resolved?
So then we can go for, we can either try using a different anti-VEGF molecule, or we can even go for lasers, pan-retinal photocoagulation.
Is it useful?
The efficacy is...
Without neovascularization?
Sorry, sir?
Without neovascularization, PRP useful?
So for macular edema, when...
PRP useful in macular edema?
In what situation? What are the indications of PRP in CRV occlusion?
So when there's more than 2 clock hours of iris neovascularization, it is usually said to recommend it then only, sir.
NVE angle iris,
yes,
along with NVD and NVE.
NVE, yes.
What are the different studies available?
So there's
management of the CRV.
For the management of CRV, various studies was calculated comparing the efficacies of various anti-VEGFs and various steroids.
Some studies.
So cruise study was there.
Yes.
There was Horizon study. There was Copernicus Galileo study. There's
which study is done with what trial? What are the drugs tried?
So the cruise study was done for ranibizumab, sir, and Copernicus Galileo was done for aflibercept, sir.
Yes.
There was Horizon study as well, sir. For corticosteroids, sir, there was core study, and there was a score 2 study as well, sir, for anti-VEGFs, bevacizumab, sir.
What are the steroids used?
Steroids, dexamethasone is used, and implants can also be there. But implants did not show much efficacy as due to it being a steroid, it again led to formation of cataract and glaucoma again, which did not prove any efficacy better than anti-VEGF injections.
Diabetic patient produces cataract and glaucoma.
Glaucoma, yes, sir.
Drawback. Then what is the importance of the triamcinolone? Can you try that? Triamcinolone?
Yes, sir. Intravitreal triamcinolone injection could be tried, sir.
Previously, they used to try. What are the other anti-VEGFs, you know?
Sir, ranibizumab, bevacizumab, aflibercept, or faricimab. Ranibizumab, commonly known as Lucentis, sir. Bevacizumab, commonly known as the Avastin. The aflibercept as Eylea, and faricimab, sir.
Okay.
Brolucizumab is also there, so one more.
What is asymptomatic CRVO?
Asymptomatic CRVO or impending CRVO, as we call it, sir. In it, there's venous dilation and tortuosity. Multiple hemorrhages could not be very well appreciated, sir.
Type of CRVO? You see,
Sorry, sir.
asymptomatic. What is the type of CRVO? Is it ischemic or non-ischemic?
Non-ischemic, sir.
Seen in non-ischemic. Why? Why you call it as asymptomatic? No symptoms. No, only you can identify it by fundus examination.
Yes, sir, because since there's no vision loss or anything, sir,
yes, no,
it's an incidental finding on fundus.
Asymptomatic. No,
yes.
Only you can see fundus, there are collateral cells seen on the optic disc.
Yes.
Can this non-ischemic can change into ischemic?
Sorry, sir?
Can this non-ischemic can be changed to ischemic?
Yes, sir. It was noticed that about 33 to 34% of the patient progressed to ischemic CRVO after 3 years, sir.
Murthy asking one question, you know, he has typed one question. Prevalence. What is the prevalence?
Prevalence, I'm not really sure about the exact prevalence.
0.8, I think 0.8. One in 1,000, something like that. Then which type of CRVO is causing blindness, you know? And what is the cause for it?
So the ischemic CRVO would be causing much more visual loss, sir, due to the involvement of the macular and the foveolar area due to the ischemic changes, sir.
Macular edema is the commonest.
Macular edema is the commonest in non-ischemic cases, sir.
Okay, sir. Well done.
Anything, Tarak?
Sir, nothing my side.
Huh?
Dr. Siram Chandramurthy is asking how to tell the prognosis.
Yes, yes.
So the prognosis could be measured by the response of the macular edema to the anti-VEGF, to the treatment we offer to the patient, and of course in the letters gained according to the visual acuity when we follow up the patient on subsequent visits. Sir.
How many days?
Sir, even after treatment, we'll ask the patient for monthly follow-ups for 6 months, sir.
Okay.
Role of cryotherapy?
Sorry, sir?
Cryotherapy.
Role of cryotherapy, sir.
Is it useful, beneficial?
So it can be done in a complication if, say, any if the CRVO leads to any vitreous.
Vascular glaucoma.
Sorry, sir?
Intractable refractory glaucoma due to neovascularization of the angle. Even after a trial of all these things, if there is still pressure is not getting down, then you can try this cryotherapy also. Ciliary bodies, photocoagulator, by cryotherapy, you can cut down the pressure.
Yes.
Is the initial acuity, Sriram Chandramurthy question is the initial acuity, visual acuity, any role to say the prognosis?
So better than 660 vision at presentation is an indicator of a good prognosis, sir.
Good. So that is, it indicates more than 6 by 60 means always think of non-ischemic. It
Non-ischemic.
is worse than 6 by 60 or 3 by 60,
Yes.
indicative of
Ischemic CR. Yes.
apart from other RAPDs and CNPs, more number of CNPs, all those things.
Yes. Sir.
Yes, good presentation.
Okay, good.
Even though you are a first graduate, you have done it nicely. Right?
Thank you. Thank you, sir.
That's an excellent job, Dr. Raghav Gupta.
Thank you, sir.
And I thank all the examiners, Dr. Krishnamurthy, Dr. Tarakeshwar, Dr. C. Ramchandramurthy, and our mentors, Dr. Padmavati and Dr. Meenakshi, and of course our moderator, Dr. Gopal Raju, for making this short case webinar a more useful program for all the postgraduates. Thank you very much. And I think any comments from any of the ARC members?
ఇంకా మరింత ఉత్సాహంతో చేయాలి.
Yes, sir. Yes, sir. Yes,
Yes.
sir. It was a very good
Yep.
presentation, sir. And both the examiners, they did a very good job, sir. Usually very informative to the PGs. And I congratulate the mentors, sir, for selecting good cases and making them as good presentators. Thank you, sir.
It should continue, Rajesh. Successfully, this should go on forever.
Yes. We are definitely running after the
It's a proud of
HODs and all the professors to select their postgraduates and I request all the professors and all the postgraduates to actively participate in this.
సార్ చిన్న రిక్వెస్ట్, నాట్
Yes.
ఓన్లీ పోస్ట్ గ్రాడ్యుయేట్స్, డిఎన్బి ప్రైమరీ డిఎన్బి క్యాండిడేట్స్ ఆల్సో కెన్ పార్టిసిపేట్.
Yeah, they are also postgraduates.
Yes, already one DNB presentation
presented.
was done,
Last time presented DNB.
Last time she presented one of the DNB candidate.
Yes.
So we can call it a day. Thank you all very much. Good
Bye.
night, everyone.
Good night, everyone. Thank you.
Thank you, sir.
Thank you. Good night to all.
Thank you, sir.
Thank you.